Hello, I'm Kieran Hagney. I'm a GP in Oldham, and I'm a GP trainer, and I do the half-day release for Salford and Trafford training as well. And I'm talking today about Down syndrome and learning disabilities. I will say I'm not an expert on learning disabilities. I'll explain why it's become something that's important to me fairly recently. I know some people in the audience have already heard this talk before. I'm sorry, I've changed it slightly just to try and keep some interest. Yes, I think let's see if this works. One second. Okay, just to get your minds active, just got a little question for you. So Emma comes to see you with her mother. Emma is 35, has Down syndrome. Her mother reports Emma has been tired recently. She often doesn't want to go to the daycare centre, which she usually enjoys. Her mother says she seems to be more forgetful. So it's a bit of a silly question, there's no right answer, but which diagnosis would you consider first? I'll just give you a few seconds just to think what might be going on there. And then see if you thought of any of these. So hypothyroidism, depression, menopause, dementia, or the get out of free jail card, all of the above. I mean, there's no right answer to this, but it's just to get you thinking about the sort of common conditions in Down syndrome that we're going to go through a bit later on. I think if you desperately wanted an answer in terms of likelihood, probably hypothyroidism and depression were probably two more likely ones. People with Down syndrome do get menopause sometimes a bit earlier, but it's usually in the 40s. 35 is still a bit early. And dementia, again, learning disabilities teams will often do screenings for dementia from 30 onwards, but it's kind of more 50 plus really, but sometimes 40 plus. So 35 would be quite early to be getting dementia in Down syndrome. I'm going to play the inspiration and why I've become very into Down syndrome and learning disabilities. This is Eddie, this is my nephew. And he, my sister's baby, and she's given me permission to tell this story because it's a sad one. When I told this last time, I got a bit emotional. I'm going to try and get through it without getting upset. But he was born in December 2022, and he was diagnosed with Down syndrome antenatally. I'm going to talk a bit about that later on as well. And when he was having his scans, the only real problem was duodenal atresia. So he had to have an operation when he was born to fix his duodenum, which was fine, went okay. And this was at Children's Hospital in Manchester. And he was recovering okay from that. And then he started to get ascites. He started to get swelling in his abdomen, and they weren't really sure why. And they thought maybe it was to do with the operation. So they opened him up again, and they couldn't really find where this was leaking from. And then, sadly, he just, over a period of a few weeks, he would just started to really swell up everywhere. So his limbs were swollen, his face was swollen, and they just couldn't control it. And his organs started to shut down. And then he died in April last year, 2023. And obviously, awful time for my sister and the family. And particularly difficult because there was never really an answer. There was never really an explanation to why it happened. I don't know if you know, when a baby dies, there's a post-mortem, obviously, and a coroner's report. It takes like 9 to 12 months for that to come through. And so that only came through a few months ago. And the cause of death is like liver failure, kidney failure due to ascites. There's no real explanation. There is a kind of description in the report that says people with Down syndrome sometimes are more likely to have this kind of problem, but it doesn't really identify what the problem is. And really what was particularly frustrating is that no child should be dying, whether for unknown reasons, whether you've got 46 or 47 chromosomes really. And you know, don't blame anyone. I think the hospital did as much as they could, and if he was born anywhere else, it would have been the same outcome, I'm sure. But to me, it felt like a sort of failure of research. And I think we know that research doesn't really happen in sort of deprived communities or disadvantaged communities as much. So for me, it was about research. So we did what anyone does when someone in the family dies. You started running, raising money because you feel a bit helpless and you don't really know what else to do. Here I am. This is Eddie's dad on the left, and these are two of my friends that we did it with. So Eddie's dad raised money for Positive About Down Syndrome, which is a charity that helps sort of new parents of children with Down syndrome in terms of information and support, which they used and found helpful. And because I was angry about research, we did it for Down Syndrome Research Foundation UK. And through that's a half marathon we did in Morecambe. And through various fundraising things, we're up to about £25,000 or something still raised in the last year or so. I think it's because you feel a bit helpless, really. Otherwise, I think when a child dies, particularly, you just want to do anything. And I think it's kind of why I'm doing this as well. When I really think about it, it's trying to, because although clearly research has been poor for him as a newborn baby, I think we can assume that probably research is poor for people with Down syndrome throughout their life as well. And although Eddie never saw primary care, I know primary care, so I can talk about Down syndrome to you guys and just try and, I know you all know about Down syndrome, but it's just trying to bring it to the forefront of your mind and just remind you about it and just make you reflect and think, am I doing the best for my Down syndrome patients? That's my sort of aim here. So, I'm going to bash through this couple of slides because I feel like you probably know this. I've done this a few times for sort of trainees and things like that, and I go into a bit more detail, but I'm going to bash through because you know all this. But barriers to healthcare for people with Down syndrome and to an extent for people with learning disabilities. So there's a lack of understanding about Down syndrome and conditions more common in this group, so we're going to talk about those. Diagnostic overshadowing. I hope you all know about that, but that's where somebody has an overriding condition, for example, Down syndrome, and when they present with a particular symptom, it's put down to that overriding symptom. Oh, it's probably their Down syndrome. So in that question that we did before, where that patient, Emma, was getting forgetful, if you're going to do some diagnostic overshadowing, you say, oh, well, she's got learning disabilities, her forgetfulness will be because of that. But actually, there was lots of other potential physical problems that could have been an issue. And Down Syndrome Association, which I've used a lot for these resources, they have a lot of stuff on their website, sort of quite awful stories of mainly secondary care, I would say, but some primary care ones. A lot of diagnostic overshadowing examples that are not very good. People with Down syndrome less likely are able to self-report health issues, of course, more likely to be reliant on family members. There's often difficulties with spoken language and communication. They also have difficulties describing and locating pain. People often describe pain in ways that we're not used to, or describe it in their own way. So being aware of that particular patient, and their carer is probably likely to know how they themselves describe pain. They often have difficulties with short-term auditory memory, making it hard to take in information through hearing. We know that they have hearing and sight difficulties. And I assume we'll send out these slides, you can have them. I've put some links to some further information about those. You all know about reasonable adjustments. And I'm just going to quickly go through a little mnemonic just to remind you about reasonable adjustments. I just want you to think, because we're going to think about it later, is with regards to how learning disability reviews perhaps are done in your practice. just when I'm talking about this, just think about how you do them and whether you are putting in these reasonable adjustments to ensure that learning disability reviews are done. So time, really important. People with Down syndrome need time. You need to talk slower, and you need to give them time to process what you're saying. And if you think about it, it'll often come with a carer as well. And so you might have to explain things twice. You might have to explain things in a way that the person with Down syndrome will be able to understand, in a way in which their carer will be able to understand, which might be slightly more complicated. And you might need to use pictures, you might need to use different methods, and all that's going to take time. So it's often the communication part that takes time, but you need to put that into your organisation. Are your learning disability reviews long enough? Are your when they attend for just general appointments, are they long enough as well? Think about your environment. Is it too hot? Is it too noisy? Is it too busy? How can you make the environment more suitable for them? This is for all people with learning disabilities and also autism as well. Attitude. I assume, because you've come to this kind of talk today, that your attitudes towards people with learning disabilities is a positive one. But there is lots of documented poor attitudes to people with learning disabilities and with Down syndrome. Although I'm sure your attitude is positive, it's about, think about other people in the practice. What are their attitudes? Are they someone who's going to rush them, or are they going to give them time? Communication, of course, we're going to talk about that in a second. And considering the help that they need, do they need the carer to come through with them? In times of COVID, letting somebody bring someone in rather than only having one person in the room, that kind of thing. So in general, if you're thinking about, am I doing reasonable adjustments appropriately, you can think of the TEACH acronym there. Just Down Syndrome Association, they have a very good website with lots of information, and they have lots of easy read leaflets that you can share with your patients with Down syndrome. So this is an example of one about thyroid, and it just has lots of pictures and few words, and so it's a little bit more understandable for them. And there's one for all different sort of conditions. I just wanted to mention something about Makaton as well. So a lot of young people with Down syndrome, because of hearing problems, because of communication difficulties, difficulty speaking, they will use Makaton. Makaton, similar but slightly different to British Sign Language. It's a language program which uses symbols, signs and speech, as opposed to British Sign Language, which isn't really speechy. And the signs are used with speech in spoken word order. And I thought, particularly good, because it's the end of the day, we might do some. Because imagine if you are a 7-year-old child with Down syndrome, you go see the doctor, and the doctor knows some Makaton. Oh, you'd be blown away. So stand up. This is the new bit. We'll see how it works. Okay, so I'm going to do it. You just repeat after me. You have to say it too. So, hello. Hello. How are you? How are you? Good.
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 Bad. Bad. Very bad. You have to say it really angry, like very bad. Because you're also using facial expressions and you're also using this. Because they can hear a bit, so you have to say very bad. Yeah. It's a hard one. Okay. It's a few words. So, my name is.
My name is.
My name is.
My name is.
Good, lovely. Can you guess this one? Doctor. Doctor. It's not technically accurate, but that's the way they do it. So, doctor. Doctor. Nurse.
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 Hospital. So it's a cross and then a building. Hospital.
Hospital.
Brill. Okay. Nearly there. I'm just giving you health-related ones that you might want to use. Medicine. So little finger. Medicine. Say it loud.
Medicine.
Thank you. I get medicine.
Medicine.
Okay. And then the last one is pain.
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 And it's a good one because you can put it where you have the pain. So tummy pain,
Pain.
knee pain,
Knee pain.
throat pain.
Throat pain.
Okay. And last one. Can you do my name is?
My name is.
Yeah. Dr. Hagney. There you go. Okay. Genius. Okay, so I'm going to bash through this. How do you plan? Okay. I'm going to bash through this quite quickly. I go into a bit more detail when I'm doing the training, but these are the conditions that you're probably more likely to see in people with Down syndrome. The more research that is done in people with Down syndrome is that they're probably a more heterogeneous group than perhaps realised. We're not saying that everyone with Down syndrome has these conditions, they're just slightly more likely. And there'll be one person with Down syndrome will be very different to another. So it's important not to assume that they all have the same stuff. So probably the most important one in terms of risk to life, I suppose, is congenital heart disease. 50% of babies will be affected in some ways, the most common being atrioventricular septal defect. And these will usually get picked up at birth. They will automatically all have an echo, whether they've got a murmur or not. So it should be picked up. Obviously, if you're doing a baby check at 8 weeks, it's just worth making sure that that's been done. Surgery is very successful now. You know, it wasn't available so much in the 70s, 80s. After that, it started to get more available. When attitudes started to change, there was a lot of opinions back when they could have done it in the 80s, where it was like, what's the point? They've got Down syndrome. You know, it was that sort of awful attitude that were happening. But now that's not so much. So that surgery is best done sort of soon as, really. I think if you leave it past sort of 6, 7, 8 months, the sort of prognosis is poor. But this will generally be picked up in hospitals anyway. Gastrointestinal problems, so like Eddie had duodenal atresia, but Hirschsprung's and celiac is very common, and that's one worth us remembering, actually, because I think if you've got a child with Down syndrome or adult with Down syndrome who is presenting with any sort of slightly GI symptoms, you might want to think about whether you want to test for celiac disease, particularly if they've got family history as well. Sleep-related upper airway obstruction is common because of anatomical differences, small upper airways, large adenoids, protruding tongue. Their muscles have less tone, and obesity is more common. So through PEDS, they should be having regular sleep studies annually up until they're about 5 years old. Move on to it. Another one that's probably important for us to be aware of is respiratory infections, and the immune system in children with Down syndrome develops more slowly. Immunisations is really important. Remember, on the COVID shielding group, people with Down syndrome were on there because of their poorer immune system. Hearing problems are common, mostly conductive, and again, through PEDS they will have regular sort of hearing screens and checks. Visual problems are common. Make sure they're having their eye check. Delayed motor skills. I would say there's a wider range. So where children, if you talk about gross motor skills, where children who don't have Down syndrome will probably walk, somewhere between, I don't know, 10 and 18 months, really. The range for a child with Down syndrome is probably 12 months to 4 years. So it's just a much broader range. So some will actually walk potentially quicker than a child without Down syndrome, but a lot might be a bit more delayed because of their reduced muscle tone. Another important one, which I will admit I did not know about until I was kind of learning more about Down syndrome. Probably I should have done. This was on the news recently. I don't know if you saw Sally Phillips the actress comedian has a child with Down syndrome, and they weren't allowed to go to a trampoline park because they wanted a letter from the GP to say that they didn't have this. But atlantoaxial instability, so between C1 and C2, it's present in 15% of people with Down syndrome, and then within that, you can sort of 1 to 2% can get spinal cord compression. So the important thing to be aware of are these things. So if somebody with Down syndrome is presenting with neck pain, change in head position, torticollis, change in tone, incontinence, change to gait, anything sort of neurological that you're thinking I need to neurologically examine you, it's worth thinking about atlantoaxial instability because they probably need a fairly imaging scan. Hypothyroidism, I think we're all aware of that. It's quite common in people with Down syndrome, so just be aware.
When did the atlantoaxial kind of present?
Could be anytime, yeah, anytime. The acute myeloid leukemia, so sounds a bit scary, that's 150 times more likely compared to children with Down syndrome, and mainly children, so between 1 and 5, but it is more responsive to chemotherapy, and disease resistance and recurrence is uncommon, so it's treatable. So I think if you're seeing a child with Down syndrome who's presenting with persistent infections, I think you need to bear that in mind. Testicular tumours, so 2 to 3 times more likely compared to men without Down syndrome. I would say that, if we try and be positive for a second, is that solid lump tumours like breast, colon, they're less common actually in people with Down syndrome, but this is an exception. Testicular tumours are more common. And it's just worth thinking about who's checking, because if you're doing an annual learning disability review, is this person in front of you able to check themselves? Would they reliably be able to check for testicle lumps, and should you be doing it? I'll probably be having a fairly low threshold to be doing it in your learning disabilities reviews. And dementia, so average onset in 50s, but like I said in that question, if suspected, make sure you check for hypothyroidism, depression, hearing problems, and menopause. I just want to touch on a subject which is a bit sensitive, but it is one that is affecting the Down syndrome community. It is of concern to them. So prenatal testing wise, at the moment you'll probably be aware there's a combined test. So they do bloods and an ultrasound and they check for the nuchal translucency. And the screen is positive if the risk is higher than 1 in 150. And if the lady gets a positive screen, then she is in a lot of places now. I'm not sure it's fully available, but a lot of places do have it. My sister had it. Is this blood test called non-invasive prenatal testing. And this examines small fragments of cell-free DNA, which are released from the placenta. And it can tell you with pretty much almost certain accuracy whether the child is going to have Down syndrome or Edwards or Patau's. Seems great. I don't know if you've ever thought of this, I haven't really considered it, but what do you think the termination rates in Down syndrome confirmed pregnancies are? France, it's 77%. In the UK, Germany, and Belgium, it's over 90%. And in Denmark, 97%. Iceland, 99%. Essentially, hardly any babies with Down syndrome are born in Denmark and Iceland anymore. And when 26 hospital trusts that provided this test saw a 30% drop in Down syndrome birth rates between 2013 and 2017, which has led people with Down syndrome to feel like they're being screened out, essentially. So they have campaigns saying, literally called "Don't Screen Us Out." Again, there was the link is there if you're interested in reading a kind of quite a good kind of balance up, really. How can we sort of preserve women's autonomy while promoting the rights of people with disabilities? There's some people that have taken the government to court to try, because obviously you can terminate a Down syndrome pregnancy up until term, but they've taken the government to court and said it should be the same as everyone else. They've not been successful in that, so it's still the same. I think they were going to take it to the European Court of Human Rights. But the Down Syndrome Association, I think, have a fairly sensible kind of sort of opinion on it, or way of sort of managing it. So this is what they say. So it's a bit long, but I think it's worth going over. So the Down Syndrome Association would not want to see a world without people who have Down syndrome. People who have Down syndrome make an enormous contribution to their families, local communities, and society in general in all sorts of different ways. We acknowledge that prenatal testing is a routine part of antenatal care, and that is a matter of individual choice as to whether to have prenatal tests or not. At the Down Syndrome Association, we are committed to ensuring that all potential parents and professionals are made aware of the joys and challenges of having a child who has Down syndrome. Before and during testing, easily understood and up-to-date information must be provided in an unbiased way by well-trained professionals concerning the accuracy of tests and associated risks, the life prospects of people who have Down syndrome, the impacts on families, the support available in the community, broad and non-directed counselling services for those who may need it, and we expect respect and support for parents making choices about antenatal tests and their outcomes, whatever they decide to do. So I just thought I'd put that in there because it is a big deal for the people, the community of Down syndrome. Let's see if this works. I don't know if anyone's seen this. This went a little bit viral a few months ago in March. World Down Syndrome Day is March the 21st. So 21 for 21 chromosome and 3 for the 3 of them. Did that make sense? And this is a really good effort just to kind of challenge attitudes towards people with Down syndrome. I've watched this about 1 million times. Let's see if it works.
Hey bartender, you assume that I cannot drink a margarita, so you don't serve me a margarita? So I don't drink a margarita. Your assumption becomes reality. And parents, you assume that I cannot live on my own, so you don't encourage me to live on my own, so I don't live on my own. Coach, you assume that I cannot hit harder, so you don't train me to hit harder, so I don't hit harder. And teacher, you assume that I cannot learn Shakespeare, so you don't teach me Shakespeare.
Old MacDonald had a farm.
So I don't learn Shakespeare. E-I-E-I-O. But hey, if all your assumptions become reality, then assume that I can drink a margarita. Will you serve me a margarita? So I drink a margarita. Assume that I can live on my own. So I live on my own. Assume that I can hit harder. So I hit harder. Assume that I can learn Shakespeare. So, what fools these mortals be! I learned fucking Shakespeare. You assume I can't swear, right? Assume that I can do that job. That I can go to parties. That I can have sex. That I can be on stage. Assume that I can. So maybe I will.
So my last thing really, this hasn't come out. I did it on a MacBook and I moved to PowerPoint. It's just thinking about how does your practice carry out learning disability annual reviews, and are they as good as it could be, shall we say? Because I know if you're a partner in a practice, then you probably do have quite a lot of power to do it in the best way that you can. If you're a salaried GP, even though you might not feel that you've got control, you've definitely got influence. And you can go back to your practices and say, actually, we do it this way, but could it be slightly better? Could we give them more time? Could we provide more continuity and things like that? So I don't know, I know Laura's coming up as I've got to finish. Is there anybody who thinks that they just do it quite well and would just be happy just to share just like 30 seconds of sort of good practice, because I want to focus on the positives? Anybody? It's Rachel here. She can't. Does that mean everybody could do it a little bit better? Because that's fine. And I hope I've inspired you to maybe do it a little bit better. I will just say, Rachel, who did the safeguarding talk before, she told me briefly when I did this last. I think she does all of them in her practice, which is great. She's been doing it for years. She's established this relationship of continuity for over a long period of time. I think that's really important and really powerful. She knows them, they know her, and I think if you can get that in the practice, I think is one example of a really good way to do it. But yes, okay. And very last thing, I'm running again. I'm doing a marathon. I'm doing the Dublin Marathon. I've never done a marathon before. I might die. So please, if you want to sponsor me, you can just scan that QR code, and I will love you forever. Thank you very much.